Think about a virus that can act like, well, like two totally different things. For some, it's barely noticeable, maybe a slight cough. For others, it's devastatingly fatal. It's this dramatic split we're really digging into today. And let's be honest, sometimes you're just drowning in information right now. You just want the key stuff, the essentials. That's our goal here.
Yeah.
We're tackling equine adenovirus, EADV, specifically in foals. It can be a really heartbreaking topic, actually. Our mission for this deep dive is to unpack how this one virus, EADV, leads to such wildly different paths, from almost nothing to a fatal illness. And it all hinges on one thing: the whole's immune system. We're pulling from specialized vet studies, expert insights, trying to give you that clear shortcut to understanding this really critical piece of equine health. Okay, so to start us off, what is equine adenovirus? Like, fundamentally, what are we looking at?
Well, at its core, EADV is a DNA virus. It's double-stranded, part of the Adenoviridae family. And interestingly, it's non-enveloped.
Non-enveloped, what does that mean in practical terms?
It means it's tough, really tough. Highly resistant in the environment because it doesn't have that protective outer layer that some viruses do. It makes it harder to get rid of.
Okay, so it hangs around.
Exactly. And it's pretty host-specific, primarily hitting horses. We mainly talk about two types. There's EADV1, which has historically been linked more with respiratory problems, sometimes GI signs too. And it's particularly nasty in foals with immune issues like SCID.
SCID, we'll definitely come back to that. And the other type?
That's EADV2. It's been identified more recently, and it's mostly associated with diarrheal disease in foals.
Got it. So it's tough. It sticks to horses and has these two main flavors. How does something like that get around so easily in horse populations? It sounds like it would be everywhere.
It pretty much is. It's widespread globally. We see what's called high seroprevalence.
Meaning lots of horses have antibodies. They've encountered it before.
Precisely. Many horses have been exposed. And here's a key thing. A major source of infection can actually be clinically healthy carriers. Adult horses, looking perfectly fine, but shedding the virus.
Shedding it how?
Subclinically. So in their respiratory tract, in their feces, without showing any illness themselves. And of course, foals that are actively sick are shedding a lot of virus too.
Wow, okay. Healthy carriers make control tricky, I imagine.
Absolutely. It adds a layer of complexity.
So how does it actually jump from horse to horse then? What are the routes?
Several ways. Aerosol transmission is a big one. Breathing in respiratory droplets. Direct contact, like nose to nose.
Makes sense.
Then there's the fecal-oral route. Contaminated feed, water, bedding, the general environment, and don't forget fomites.
Fomites. Remind us.
Oh, sorry. Yeah, that's just inanimate objects. So equipment, buckets, clothing, even our hands can carry the virus between horses if we're not careful.
Right. Basic biosecurity stuff.
Okay.
So knowing how it spreads,
right,
what makes a particular foal more likely to get sick from it, not just exposed? Are there specific risk factors?
Yes, definitely. Age is a major one. Young foals, typically we're talking 1 to 6 months old, they're the most susceptible to showing clinical signs.
Okay, young one.
And stress, big factor. Things like weaning, transport, overcrowding, even poor ventilation in the barn. All that can predispose them.
Makes sense. Stress weakens the system.
Exactly. And then there are co-infections. If a foal gets EADV at the same time as, say, equine herpes virus or rotavirus, it can really amplify the disease, makes everything worse.
Okay, so it rarely acts alone in severe cases, potentially.
You can compound things, for sure.
Now, let's connect this back to the foal itself. What's actually happening inside? Because this is where it gets, well, really interesting, like you said, depending entirely on that immune system.
It really does, and it highlights just how fundamental a healthy immune response is. So, EADV, it likes to target epithelial cells. These are the cells lining the respiratory tract and the GI tract.
Okay.
It gets inside, replicates, and basically causes those cells to burst, causing damage. Now, in most foals, the immunocompetent ones.
Meaning the ones with a normal working immune system.
Exactly. Their immune system mounts a pretty robust response. It usually clears the infection within, say, 10 to 14 days.
So relatively quick.
Yeah. And the result is often subclinical disease, no signs at all, or maybe just very mild signs. The cell damage might make them a bit more vulnerable to secondary bacterial infections, but generally they bounce back fine.
Okay, that's the good scenario, relatively speaking. But then there's the other side of the coin. You mentioned SCID earlier, severe combined immunodeficiency. This changes everything, doesn't it?
Completely. It's not just a worse version of the mild disease. It's a fundamentally different process. SCID is a genetic condition. We see it primarily in Arabian foals and Arabian crosses.
A genetic defect. What does it do?
These foals are born essentially without functional T and B lymphocytes. Think of these as the main soldiers, the key players of the adaptive immune system. They recognize specific threats and coordinate the attack.
So without them.
Without them, they just can't mount an effective defense against the virus.
Nice.
So EADV isn't controlled, it just replicates unchecked, goes rampant.
What does that lead to?
It leads directly to severe progressive bronchial pneumonia. That's often the primary cause of death. If you look at tissues under a microscope, you can often see these characteristic signs, inclusion bodies inside the respiratory cells.
Viral footprints almost?
Kind of, yeah. And the virus doesn't just stay in the lungs. It can spread, disseminate to other organs, the gut, liver, pancreas, causing widespread damage. Plus, this profound lack of immune defense makes them incredibly vulnerable to secondary infections, bacterial, fungal, anything really. Their body just can't fight back.
It sounds absolutely devastating. You also mentioned Fell-Pony syndrome. Is that similar?
Yes, that's another group known to have compromised immune systems where EADV can also cause severe, often fatal, disease. The underlying mechanism might differ, but the vulnerability is similar.
Okay, so the contrast is just incredibly stark. Let's shift to what someone might actually see. How do the clinical signs differ between a regular foal and one with SCID?
Yeah, that's a critical question, isn't it? How can you tell them apart early on? For the immunocompetent foal, the signs, if any, are usually mild.
Like what?
Well, maybe a slight fever, but it's often transient, doesn't last long. Maybe some clear, slightly watery nasal discharge, a mild, kind of moist cough. And follicular conjunctivitis is quite characteristic.
What's that look like?
It's a specific inflammation of the lining of the eye, looks kind of bumpy. You might also feel slightly enlarged lymph nodes under the jaw. Rarely, maybe a little bit of difficulty breathing. If it's more the diarrheal type, EAD2, you'd see soft manure or mild diarrhea, but usually the foal doesn't seem systemically sick.
Okay, so fairly mild. Maybe easy to miss sometimes.
Could be, yeah.
But for the SCID foals, or those with Fell-Pony syndrome, it sounds like a completely different picture. When do those signs typically show up?
It's usually around 1 to 3 months of age, and that timing is significant. It's right when the maternal antibodies they got from the mare's first milk, the colostrum, start to wear off.
So their own immune system is supposed to take over, but can't.
Exactly. That's when the lack of their own immunity becomes tragically apparent. And the signs are severe and progressive. We're talking persistent fever, maybe intermittent at first, but it stays. Lots of thick, pus-like, nasal discharge, mucopurulent.
Nasty stuff.
Yeah, and a severe, persistent cough. You'll see them having trouble breathing, progressively worse, increased effort just to take a breath.
Did you hear it?
Often, yes. Listening to their lungs, you might hear crackles or wheezes. In the later stages, you might even see cyanosis, their gums turning bluish because they're not getting enough oxygen. It usually progresses rapidly to a severe bronchial pneumonia that just doesn't respond to antibiotics.
Because the underlying problem isn't bacterial, it's the virus running wild and the lack of immunity.
Precisely. And you often see significant GI signs too. Chronic, severe diarrhea, they lose their appetite, become unthrifty, lose weight dramatically. Just overall severe lethargy, depression, weakness, failure to thrive.
And the outcome?
Sadly, it's invariably fatal in SCID foals, usually within weeks after the clinical signs really start.
That's incredibly tough. So faced with these possibilities, how do vets figure out what's going on? How do they diagnose EADV? And critically, how do they confirm SCID?
Well, clinical suspicion is the first step, of course, based on the signs we just talked about, and importantly, the breed. If you have an Arabian or part Arabian foal showing those severe signs at that age, SCID has to be high on your list.
Okay, breed is a big clue. Then what? Labs.
Yes. For detecting the virus itself, PCR polymerase chain reaction is generally the preferred method now.
Why PCR?
It's very sensitive and specific. It looks for the virus's DNA. You can run it on samples like nasal swabs, fecal samples, eye swabs, even fluid washed from the trachea.
So it tells you if the virus's genetic material is there.
Exactly. But, and this is important, a positive PCR confirms the DNA is present, but it doesn't automatically mean that EADV is causing the current clinical signs, especially since we know healthy carriers can shed the virus. Context is key.
Right. It proves presence, not necessarily causation in every case. Are there other ways to detect the virus?
There are. Virus isolation is possible, but it's slower. Electron microscopy can sometimes be used. And histopathology, looking at tissue samples under a microscope, maybe from a biopsy or a necropsy, can show those characteristic intranuclear inclusion bodies we mentioned.
Okay. But how do you nail down the SCID diagnosis itself? That seems crucial.
Absolutely crucial. And this is where modern diagnostics, especially genetics, have been a game changer. It lets us find that hidden vulnerability.
So how is SCID confirmed?
Well, basic blood work can be highly suggestive. SCID foals typically have profoundly low lymphocyte counts, those key white blood cells, often less than 500 cells per microliter. That's a huge red flag.
Less than 500.
Wow. Yeah, it's drastically low. We can also look at immunoglobulin levels, specifically IgM. Before they get colostrum, SCID foals have no IgM. After colostrum, you might need to wait a few weeks for the maternal IgM to decrease to see the deficiency. But the definitive gold standard diagnosis.
Genetic testing.
Genetic testing. There's a specific test for the gene mutation responsible for SCID in Arabians. That gives you a definitive yes or no.
That's powerful. Okay, so let's say the diagnosis is made, EADV is confirmed, and maybe SCID is too. What happens then? What are the treatment options, and what's the prognosis? I suspect it's, again, two very different stories.
You suspect right. And that stark difference in prognosis, from potentially excellent to essentially zero hope, it just hammers home how vital that immune system is. The first thing to know is there's no specific antiviral drug for EADV.
No magic bullet for the virus itself.
No. So treatment is all supportive and symptomatic, managing the signs.
Okay, let's take the immunocompetent foal first. What does supportive care look like for them?
For them, it's usually about rest, making sure they're in a clean, dry, well-ventilated place. We might use NSAIDs, non-steroidal anti-inflammatories, to manage fever or discomfort. Antibiotics are generally only used if there's clear evidence or strong suspicion of a secondary bacterial infection taking hold.
Right. Don't want to overuse antibiotics.
Exactly. If there's diarrhea, fluid therapy might be needed to prevent dehydration. But honestly, with good basic care, the prognosis for these foals is excellent. Most recover completely without any lasting issues.
Okay, that's good news for most foals.
Yeah.
But SCID foals?
Yeah. For SCID foals, the prognosis is grave. Treatment is generally considered futile once they're showing significant clinical signs.
Futile, meaning nothing helps.
Pretty much. You can provide supportive care antibiotics for the inevitable secondary infections, fluids, nutritional support, but it very, very rarely changes the outcome. It might prolong things slightly, but doesn't prevent the fatality.
So, what's the recommendation then?
Often, sadly, euthanasia is recommended. It's based on the progressive nature of the disease, the poor quality of life, and the lack of any effective cure. It's a really difficult decision for everyone involved.
I can only imagine. Are there any experimental things you sometimes hear about bone marrow transplants?
They have been explored, yes. Bone marrow stem cell transplants could theoretically provide the missing immune cells. But the sources we looked at state pretty clearly that for SCID and fell pony foals showing clinical signs, treatment is generally not productive. It's complex, expensive, and often too late.
Right. So prevention becomes absolutely paramount, especially for SCID. What does this all mean for you, the listener? If you're breeding horses or managing foals, how do you prevent this?
This is where understanding the why, like the genetics of SCID, really empowers people. It allows for truly proactive prevention that's way more effective than just reacting to symptoms.
Okay, so break it down. Prevention for the average immunocompetent foal first. What can people do?
It boils down to really good general management and biosecurity. Minimize their contact with transient adult horses that might be shedding carriers. Practice strict hygiene hand washing, cleaning equipment between horses. Ensure good ventilation in barns. Quarantine any new horses arriving on the property.
Standard biosecurity protocols.
Yep. And manage stress. Try to minimize weaning stress. Avoid overcrowding. Good nutrition is also key to supporting a healthy immune system. But one crucial point.
Yes.
There is currently no commercially available vaccine for equine adenovirus.
No vaccine. Okay, that's important. So management is everything for the general population.
Right.
Now, what about preventing SCID in Arabians? That sounds like a different strategy altogether.
It is, and it's incredibly effective because it tackles the root cause. The single most effective prevention is to identify carriers of the SCID gene through genetic testing and then avoid breeding two carriers together.
There's a test available.
Yes, a reliable genetic test is widely available for Arabian horses. If you breed two carriers, horses that carry one copy of the gene but are healthy themselves, heterozygotes, the odds are about 1 in 4 that the resulting foal will inherit two copies and have SCID.
1 in 4. That's a significant risk.
It is. So the recommendation is clear. Test breeding stock and do not mate two carriers. It's also wise to consider testing Arabian foals during pre-purchase exams, especially if they're destined for breeding or a high-level performance career.
That makes perfect sense. What about the fell pony syndrome? Any similar genetic tests?
Recommendations aren't as established yet for fell ponies, but the potential for developing specific genetic testing for the mutation involved there certainly exists for the future. Research is ongoing.
It's really quite something, isn't it? This one tiny virus, EADV, but it creates these two completely separate realities for foals. We've seen it can be just a mild blip, or it can be this relentless, fatal disease. And the decider is the immune system. In Arabians specifically, it's often predetermined by that hidden genetic flaw, SCID. Understanding that difference, whether you see in the clinical signs or you find it through genetic testing, it's everything for managing these foals, and even more so for preventing the heartbreak in the first place. So as you think about this, maybe consider this. How does this specific case, this genetic vulnerability in foals, impacting their response to a common virus? How does that change how we think about genetic predispositions to disease more broadly? Not just in horses, but maybe in other animals, even ourselves. And what does it tell us about the power of understanding genetics for truly preventative care across the board?